At a point in the process of the conduct of vaginal delivery, descent and head extension through the pelvis has occurred and the fetal head has been delivered with proper coaching and posterior perineal support. With further pushing, there is retraction of the head against the perineum. The operator notices this turtle sign and becomes aware that shoulder dystocia is a risk. The examinee will take the next steps to accomplish delivery of the shoulder. Instructs patient to stop pushing and to breathe or pant without pushing. Delivery of the anterior shoulder is attempted with proper hand position on the fetal cheeks, thumbs pointing downward. Gentle downward traction provided on the anterior cheek. No success occurs. Traction stops as safe limit of traction effort is recognized, and shoulder dystocia is called out to the team to initiate sequence of events, including extra personnel and anesthesia assistance and NICU alerts. Operator asks for McRoberts position to be accomplished, hip flexion to 45 degrees. Operator asks for the head of the bed to be lowered. Operator asks for suprapubic pressure to be applied. Assistant stands on a stool to give pressure obliquely on the presumed back of the fetal shoulder. Operator asks for time to be noted and tracked. Gentle downward traction is then repeated. If no success occurs, operator indicates this, stating shoulder not delivered. Operator states to the patient and partner that we need to try various ways to deliver the baby, which may at some point require a cesarean section. Please note, outward traction is never applied. Direction of force should be down and back in the direction of the posterior perineum and anus. This is the Hibbard maneuver. Delivery of the posterior arm is an acceptable option at any point from here. For demonstration purposes, a full sequence of acceptable options will be performed prior to demonstration of delivery of the posterior arm. Time and degree of success will require decisions regarding the order of maneuvers and when the delivery of the posterior arm should be attempted. One option is delivery of the posterior shoulder is attempted with same hand position, but with upward traction on the posterior cheek, a variation of the Gaskin maneuver not requiring patient repositioning. Another option is the Woods maneuver. Operator places hand behind the posterior shoulder and rotates the posterior shoulder 180 degrees. Another option is the Rubin maneuver. Operator places hand posterior to the accessible shoulder and pushes the shoulder toward the anterior surface of the fetal chest, causing the body to rotate obliquely and the shoulders to compress together. Another option is delivery of the posterior arm. Operator introduces a hand into the vagina along the fetal posterior humerus, maintains or creates flexion at the elbow, and sweeps the arm across the fetal chest. The fetal hand is then grasped and the arm extended along the side of the face. The posterior arm is then delivered from the vagina and subsequent delivery of the anterior shoulder attempted, aided by displacement of the anterior shoulder. Outward traction is never applied. Uterine fundal pressure is never applied. Operator assures documentation is complete and may ask for a debriefing meeting. As a supplemental option, a episiotomy is acceptable at any point if maneuvers cannot be completed without it. We will re-demonstrate some of the maneuvers with a baby outside of the pelvis for better visibility. Another option is the Woods maneuver. Operator places hand behind the posterior shoulder and rotates the posterior shoulder 180 degrees. Another option is the Rubin maneuver. Operator places hand posterior to the accessible shoulder and pushes the shoulder toward the anterior surface of the fetal chest, causing the body to rotate obliquely and the shoulders to compress together. Another option is delivery of the posterior arm. Operator introduces a hand into the vagina along the fetal posterior humerus, maintains or creates flexion at the elbow, and sweeps the arm across the fetal chest. The fetal hand is then grasped and the arm extended along the side of the face. The posterior arm is then delivered from the vagina, and subsequent delivery of the anterior shoulder attempted, aided by displacement of the anterior shoulder. Another option that is less convenient is the Gaskin maneuver. Operator asks team to turn patient to hands and knees position, places hands again on fetal cheeks, and applies traction in the direction of the bed in an attempt to deliver the posterior shoulder. Traction in direction of ceiling may also be provided in an attempt to deliver the anterior shoulder. Sequence of maneuvers or selective maneuvers may be, or perhaps should be, repeated prior to initiation of more extreme options that follow. One option that is more extreme is intentional fracture of the fetal clavicle by pulling the midshaft outward or pressing the midshaft inward, then repeats anterior shoulder delivery attempts. Another option that is more extreme is the Vaginal maneuver. Replacement of the fetal head by flexion with replacement back into the vagina by rotation to OA or OP. Use of tocolytic for uterine relaxation may be necessary, then cesarean section. Another option that is more extreme is abdominal rescue. Cesarean section incision is made to disimpact the anterior shoulder, with vaginal attendant simultaneously attempting maneuvers. Can shoulder dystocia be predicted or prevented? Risk factors can be identified, but dystocia can occur in their absence. An untested technique to avoid shoulder dystocia involves an attempt to prevent full fetal external rotation. This may prevent impaction of the anterior fetal shoulder. In order to maintain shoulders in a more favorable position to enter the pelvis, instruct the patient to continue or to initiate pushing immediately after delivery of the fetal head before external rotation occurs.
Push, keep pushing.